Morning Emeritus Chairperson, Dr. Swarnkarji, Vice Chancellor, Dr. Achal Gulati ji, Principal Sahab, Dr. Hemanth Malhotra, Vice Chancellor, Pro Vice Chancellor, Dr. Vinay Kapoor. Today the combined clinical round is being presented by the Department of Hepatology and Liver Transplantation of the MGUMST. We are one of the probably the youngest and the smallest departments in MGUMST. The department began with when Dr. Karan Kumar, as assistant professor, joined MGUMST in August of 2021 after training at the ILBS. He has been the backbone and the major impetus behind the department. I joined him a couple of months later after superannuating from SGPGI Lucknow. And our latest entrant is our DM candidate, Dr. Hemanth. So we are a department of 3 people. Hemanth will be the first DM in hepatology in the state of Rajasthan. To briefly tell you about the department, hepatology is a branch of, it is an extension of gastroenterology. Till very recently, it was part of gastroenterology, and we deal with diseases of the liver, gallbladder, biliary tract, and the pancreas. The DM program in hepatology began in the year 2007 at PGI Chandigarh and ILBS. Since then, 10 departments are now offering DM training in hepatology. And I think after ILBS, the most well-rounded department with complete training and facilities, including a very active liver transplant program, is at our center at MGUMST. So briefly to tell you what we've been doing in the last 3 years since the department came into existence. Our attendance, the green bars show the outpatient, the orange parts show the inpatient burden. Numbers are not large, but as you will see, the curve is steadily upwards and the number of patients we are admitting and managing is steadily increasing. In fact, we generally have about 10 to 15 inpatients and about 1 to 7 ICU patients on any average day in the hospital. A major contribution of the department has been in identifying, working up and preparing patients for the liver transplant program of the university. And as this graph will show you, ever since our department became active, the number of patients undergoing liver transplant has been steadily increasing. As of date, a total of 103 liver transplants have been done, and as this slides in red show, the numbers have increased significantly after 2021 August when we became active. The other important investigation or a special test we are carrying out is a non-invasive test called FibroScan, which assesses fat content, stiffness and fibrosis within the liver and gives more information than the routine imaging on ultrasound and CT scan. So after installation in the month of February last year, we have done about a total of over 2,000 procedures, and as you will see, in the last 6 months, we have done almost as much as we had done in 2023, and the number is steadily increasing. Another special area is the ERCP procedure, which of course our gastroenterology colleagues have been doing, but particularly complicated patients, pancreatic disorders and subsequent to biliary complications that are at times seen in patients with liver transplantation is something that our hepatology department is doing, and this is the total number that have happened since the last 3 years. In terms of departmental publications in 2022 and 23, we have over about 21 publications in index journals in the last 2 years, 22 and 23, 10 in national and 11 in international journals, all of which have a high impact factor, ranging from 3.3 to a paper in Lancet Gastroenterology Hepatology that has an impact factor of about 58, among the highest in gastroenterology journals. In addition, the department has been active in participating in CMEs and conferences at the national and international level. And these slides show you some of these. The blue are the national meetings, the red are the international meetings. And in the last 2 years, 22 to 23, Dr. Katyayani and I have participated in about 33 meetings, primarily in the role of speakers or panelists in local, national and international meetings, as shown here. We have also organized some conferences and symposia within the institute, within the university, and the one in blue is a midterm meeting of the Indian National Association for the Study of the Liver, which we conducted in April of last year. Subsequently, activities like World Liver Day, Global Fatty Liver Day, World Hepatitis Day, in conjunction with Professor Kapoor's initiative in Jaipur Swasthya Charcha, we have held meetings and which have been generally well attended, including the latest one 2 days ago on the World Hepatitis Day. And seminars there have been for in relation to liver transplantation have been we have been part of those in different parts of the country. Various awards have been also received by the faculty and the department. Lectures, orations and awards including the prestigious R.K. Tandon Memorial Award in the ISG, our national meeting last year, as I have done, and Dr. Karan has been participating and has received the MNAMS award last year, as well as awards from various universities. Ongoing research projects, basically we are part of multilateral and global and national consortia related to hepatitis B, an ICMR study in PGI Chandigarh on artificial intelligence in predicting the outcome of alcoholic hepatitis, as well as the national prevalence of what now is known as metabolic dysfunction associated steatotic liver disease, as well as the utility of anti-diabetic drugs in the management of NASH and MASLD. With these few words, I'll now invite our first year senior resident, Dr. Hemanth, to discuss the problems of a 21-year-old male with fever and jaundice. Before that, I'll just take a minute to ask, maybe can we have a show of hands of how many people here have suffered from hepatitis A virus infection in their life? 1, 2, I did also. So very few of us have actually had hepatitis A. How many of you are seriously thinking of getting vaccinated against hepatitis A? Anybody? Right. So that is a bit different from what is usually one experiences. Some of these questions I'll come back to at the end of the presentation if time permits, because I think this is an underemphasized and under-recognized disease about which we'll be talking today. Dr. Hemanth, will you please come and start?
Thank you, sir. Very good morning, Honorable Emeritus Chairperson, sir, respectable dignitaries, senior faculty members, and my colleagues. It is a patient, he is a 21-year-old male with fever and jaundice. He presented to the Manmohan hospital with complaints of fever since 5 days, vomiting since 5 days, and adverse discoloration of eyes and urine since the last 2 days. History of presenting as fever is of high grade, 100 to 102 degrees Fahrenheit, associated with chills and rigor, intermittent, relieved on taking medications. He is taking around 2 to 3 tablets of paracetamol per day for subsiding fever, and with no diurnal variation, vomitings 2 to 3 episodes per day, non-projectile, non-bloodstained, containing food particles, not associated with food intake, and investigated discoloration of eyes and urine since the last 2 days, which was painless, progressive, not associated with itching or clay colored stools. There is no stuff of abdominal pain, cough, expectoration, shortness of breath or pleuritic chest pain, and no stuff of burning institution, decreased urine output, diarrhea, no stuff of itching or clay colored stools, no stuff of blood transfusions, no stuff of consumption of any hepatotoxic drugs or alternative medications. And the patient does not have any comorbidities of diabetes, previous history of tuberculosis or thyroid disorders, is a non-smoker, non-alcoholic, and no history of any IV drug abuse. Past history and family history of the patient was insignificant, no similar complaints of jaundice in the past. So with these complaints, this history, 21-year-old male, resident of Alvar, student, presented complaints of fever, vomiting and jaundice for 5 days. What could be the possible probable diagnosis? Anyone?
So there can be viral hepatitis, there can be malaria, leptospirosis, it can be sepsis, or any hemolytic anemia due to or sickle cell disease.
Yeah, mostly acute onset illness, only 5 days duration with fever, acute viral illness, mostly viral infective causes. Infective causes of the first differential, which is hepatitis, acute viral hepatitis, which most commonly hepatotrophic viruses of hepatitis A, hepatitis E, and hepatitis B, and still rare non-hepatotrophic viruses of cytomegalovirus, herpes simplex virus, and Epstein-Barr virus. Tropical fever, which mimic acute viral hepatitis, or malaria, dengue, leptospira, and strep typhus have to be ruled out. And even though the patient does not have any complaints of abdominal pain, liver abscess, either pyogenic or amoebic, has to be ruled out, and cholangitis due to choledochoricidal disease has to be ruled out. On general physical examination, patient was conscious, cooperative, oriented to time, place, and person, moderately built with BMI of 20. His vital parameters were normal, and patient was having icterus on presentation. There was no cyanosis, clubbing, lymphadenopathy, or pituitary. As the patient is having icterus in examination, first on 16-week examination, patient on correct one examination, patient has normal abdomen shape, scaphoid in shape, all regions of abdomen move equally with respiration, and no direct bleeds or stars as chances are present. On palpation, abdomen was soft, non-tender, no clotting or rigidity. On depalpation, liver was palpable 2 centimeters below right posterior margin in right midclavicular line. Was smooth, forming consistency, non-tender, regular margins moving with respiration. Spleen was not palpable, and linear orifices and genitalia normal. On percussion, tympanic node present above abdomen, liver, upper border of liver dullness was present on right intercostal space in right midclavicular line, with a liver span of 10 centimeters in right midclavicular line. No fluid thrill or shift in dullness present. On auscultation, there are no such positive findings, body sounds were normal, no venous sound or arterial. Other system examination, cardiovascular, respiratory, and central system examination normal, no positive findings are present. So, with this summary and examination findings, 21-year-old male with complaints of fever, vomitings, jaundice, and for 5 days duration, with presence of icterus on examination, and no significant positive findings on examination, in systemic examination. So, differential remain the same, and we have to rule out based on the investigations. So, patient was admitted to ward, was started on conservative medical management with IV fluids, proton pump inhibitors, awaiting investigations for further management. So, following the admission, investigations on day 1 were very alarming, with almost more than 300 times elevation of enzymes, liver enzymes, SGOT and SGPT. SGOT was 13,000 and SGPT was 11,000. With the rise in bilirubin to 6.4 and rise in INR to 3.0 and creatinine, along with the rise in creatinine to 3.6. Although the patient does not have any complaints of decreased urine output in hospital admission, patient had rise in creatinine with elevated procalcitonin in both. 12 markers and tropical fever markers were sent and reports were elevated, and urine examination showing no pulses and no RBCs. Chest X-ray was normal, ultrasound abdomen was normal. Hospital course, but on day 1, after admission on day 1 and investigation, alarming investigations on day 1, day 2 patient has rapidly deteriorated in the form of altered sensorium and excessive sleepiness, irritability and disorientation. Sensorium has worsened with presence of flapping tremors. As you can see, the patient has fine flaps. So the diagnosis of hepatic encephalopathy was made, and corroborating this clinical findings, patient also has rapidly increasing ammonia value, serum ammonia value to 170, and INR has rapidly increased to 6.9 from 3 on day 1, with rising creatinine and bilirubin. In view of rapidly worsening sensorium and progressively deteriorating liver function test and renal function test, patient was shifted to ICU intubated in view of hepatic encephalopathy, as there is a risk of developing cerebral edema and brain herniation in patients with acute liver failure. So, overall summary, 21-year-old male with clinical features of fever, jaundice, and rapidly worsening sensorium, with laboratory findings of hepatocellular jaundice, coagulopathy, hyperammonemia, and acute kidney injury. The differential diagnosis of acute liver failure with acute kidney injury is differential with probable causes of infective, viral, hepatitis A, hepatitis B, with drugs and toxins of most commonly paracetamol, tubercular drugs, anti-tubercular drugs, and phenytoin, most commonly in India. With autoimmune hepatitis, metabolic, and idiopathic are most common etiological factors. Followed by tropical fever with MODS, tropical fever with malaria, dengue, leptospira, and strep typhus, and sepsis due to any cause with multiple organ dysfunction is the differential diagnosis. By the time the patient developed acute liver failure, etiological workup also turned up showing IgM HAV as positive, and all other viral markers and tropical fever markers came as negative. So final diagnosis was made, which is acute liver failure, which was hyperacute in nature. The development of encephalopathy from the onset of jaundice is less than 7 days, with etiology of hepatitis A virus with acute kidney injury stage 3. Aching stage as defined by aching stage criteria. So patient was started with management of acute liver failure protocol, and was already intubated in ICU and on mechanical ventilator support with minimal stimulation to make sure the patient does not develop cerebral edema and hernia, and started on empirical sepsis infection cover with gram positive, gram negative, and antifungal cover with correction of metabolic parameters with T2 infusions, phosphate, and potassium corrections. Even though the INR is increasing rapidly, the patient does not need FFP requirement unless until there is any bleeding manifestations. And INR is also a single most important prognostic factor to see for spontaneous recovery of liver function. So, along with after starting medical management, all acute liver failure patients are potential liver transplant candidates, and hepatopancreatic biliary surgery and liver transplant department reference was taken for further liver transplant workup. Now I would like to invite Dr. Manmohan sir to carry on.
Good morning, teachers and dear colleagues. I am Manmohan Rajput, final year MCH HPB resident from Department of HPB Surgery and Liver Transplant. Once the patient was referred to us, we needed to assess the need of liver transplant, and the most widely used tool to determine this is the King's College criteria, out of which the most important standalone factor is the INR greater than 6.5 with hepatic encephalopathy. The other 5 parameters here can be easily determined by remembering the acronym ABCDE, which includes the age, coagulopathy, the duration, the bilirubin level, and the etiology. So this is how we remember. Any 3 out of these 5 need to be positive, and our patient was meeting the criterion of INR being greater than 6.5. Hence, he was a candidate for liver transplantation. Moving ahead, talking about the role of liver transplant in acute liver failure. Liver transplant in the last 40 years has been the most significant development in the treatment of ALF. The graph here shows that in the late 80s and the early 90s, the overall survival was about 50% with liver transplantation, which has now increased to more than 80%. To select a patient for liver transplant in ALF is basically dependent on 3 criteria. The first is, what will be the survival post the transplant? And if the patient is not transplanted, what will be the survival then? These 2 need to be determined, and whether the patient is fit to be transplanted or not. So, in looking at our patient, even though the patient met the criteria for being transplantable with an INR of 6.5. However, clinically the patient had features of acute kidney injury and sepsis, which was indicated by high procalcitonin. Hence, in the current situation, the patient was not a candidate for transplant. So, during the time, as our hepatology colleagues were stabilizing and optimizing the patient, we continued to determine, to identify a fit donor for the transplant if the patient is fit enough and the cultures negative, turn out to be negative and the AKI improves. Once all of that happens, we then decided to reassess the patient at a later time. Thank you. Now I would like to invite Dr. Karan.
So, good morning everyone. So, we have a 21-year-old boy who presented very casually to the OPD with complaint of fever and jaundice. However, his labs and the pulse was alarming. He was having a multi-organ failure. His INR was through the roof. He was having AKI, enzymes running in thousands, which is surprisingly very high. So, and he was unfit for transplant. So, job in our hand was to make him fit for transplant or to either recovery. Just a brief about acute liver failure. Liver failure is not a disease of liver alone. Whenever liver is failing, there is a systemic inflammation surge which leads to multi-organ involvement. The most common and the most important organ involved and which is to be tackled in patient with acute liver failure is brain. There is a cerebral edema, rapidly developing and evolving cerebral edema which can lead to brainstem herniation. I will discuss this in a bit detail in later slides. Second is coagulation. Another thing, as Dr. Hemanth has also highlighted, INR is a prognostic marker. It is not a marker of bleed in acute liver failure. It is a common practice among the physicians and to see whenever there is a raised INR, just to correct it by giving FFPs. This is totally wrong. If INR is raised, this is only the sole criteria to determine whether the patient is improving or worsening. And despite, it has been shown that despite of having raised INR, these patients usually have bleeding tendencies. Okay, so INR is a prognostic marker rather than a marker of transfusion for FFP. Third important aspect is, as liver is an important storehouse for various nutrients, so hypoglycemia, the electrolyte imbalance occurs very rapidly in patients with acute liver failure, and frequent monitoring and treatment has to be carried out. Another important organ is renal. Almost 30 to 40% of patients with acute liver failure will have renal involvement at presentation. This is either functional because of hemodynamic compromise or maybe related to sepsis. Another aspect is infection. Liver is a major immune organ in the body. All the macrophages and other things are present in the liver. And when liver is gone, body's immune response is shut down. This predisposes patient to a lot of infection, either bacterial, fungal. The site could be pneumonia or UTI. The most important organ, as I already described, is brain. How brain comes into the picture? This is a disease of liver. Hepatitis A comes, it damages the liver, and we are talking about brain. How brain is coming into picture? Whenever we consume protein, the proteins are broken down by the gut bacteria and ammonia is generated. That ammonia reaches liver by means of portal circulation, and liver tries to remove this ammonia by converting it into urea. When liver is failing, this ammonia bypasses the liver. Liver is not able to convert ammonia into urea, and this ammonia reaches the systemic circulation. And this ammonia in blood, there is a blood-brain barrier. There are areas without blood-brain barrier, and it can cross the blood-brain barrier also. It reaches the brain, leading to entry of another osmolytes within the brain cells, leading to the swelling of brain. Brain is enclosed in a skull. When brain cells swell, they can't go out. They will only find a place of least resistance, which is the foramen magnum, and it can lead to herniation. It can happen so rapidly that within few hours, the patient, after setting up of liver failure, the brain edema can be so severe that patient can herniate. So this brain edema has to be tackled very meticulously and very carefully. So how we assess this patient, whether the patient is having brain edema or not? There are tools available. First and the foremost, the clinical signs. Pupillary reflex. If the pupils are reacting, still the brain is not herniated. Cushing reflex, which is indicated by high blood pressure and bradycardia. Radiological tool. Bedside, simple bedside ultrasound, just by keeping a probe over the eyeball, we can determine whether the brain is having edema or not. This tool is known as optic nerve sheath diameter. Optic nerve, second nerve, is in the dead continuity with the brain. If there is edema in the brain, it will transmit it directly to the optic nerve. Just by measuring the thickness of the optic nerve, we can determine whether the patient is having developing or having cerebral edema or not. Invasive tools like placing bolt into the intracranial and pressure for monitoring, it can't be practiced in patients with ALF as they are too sick for any surgical intervention. Coming back to our patient, he was having a brisk pupillary reflex, suggesting still brain is not herniated. Those signs of cerebral edema in form of Cushing reflex and ONSD of 6.2 was present, suggesting cerebral edema is still there, but brain is not herniated. We have to aggressively intervene so that before he herniates or cones, we should have to prevent that. So how to prevent that? First step is to intubate the patient. Any patient who is having cerebral edema or is at risk of developing cerebral edema, patient should be kept calm and quiet. There should be no stimulus in the room. Just like this patient, we intubated him, completely sedated, paralyzed. Even lights were switched off so that even in any case of sedation break or anything happens, there should be no stimulus. Nurses are told to keep the phones on in silent mode, and there should be no noise or sound in the room. Apart from that, the head end is kept elevated, ventilator settings are made so PCO2 is kept at around 35, as CO2 is a vasodilator, it can also alter brain blood flow. Hypothermia is targeted, temperature is targeted around 95. We target hyperosmotic solution like 3% normal saline to prevent cerebral edema. In patients who have normal kidneys, mannitol can also be given. This is the thing we are doing to, already cerebral edema has set in, brain is involved, we are trying to prevent that further exacerbation. How to treat the thing which is causing the cerebral edema, which was ammonia. How we can remove the ammonia from the body. For that, we have to use the principle of simple dialysis, that is ultrafiltration, convection or diffusion. But as in case of dialysis, these things can be removed by dialysis also, but the removal will be so rapid that sudden osmolyte shift can even exacerbate the edema. To tackle this condition, there is a modality known as CRRT, continuous renal replacement therapy. It is just like a dialysis machine based on principle of ultrafiltration, convection and diffusion, but it occurs that the blood flow is so slow that it is just, you can just compare it at a dialysis which normally gets completed in 2 to 3 hours. It is a dialysis occurring over a period of 72 hours. So slow that the ammonia and the other toxins are removed slowly. In coming to back to this, what is the role of CRRT in patients with acute liver failure? Those who are having renal dysfunction, hyperammonemia, hepatic encephalopathy above grade 2 or metabolic abnormalities are candidate for CRRT initiation. Our patient had renal dysfunction, hyperammonemia, hepatic encephalopathy, in fact all the three, so he was started on continuous renal replacement. King's College criteria that he has discussed earlier. So after starting this continuous renal replacement therapy, as you can see that there was dramatic improvement in the liver functions as suggested by improvement in INR, which was in the range of 6.9. After 8 days for continuing CRRT, this INR becomes 1.1. Another thing, INR is not improved by CRRT. Improvement in INR is a marker of liver recovery. That's why I emphasize that FFP should not be given to the patient. As the patient has improving INR, improving SGOT, SGPT, improvement in edema, like decrease in ONSD from 6.3 to 4.9, all these things suggestive of improvement in the cerebral edema and the brain function. Another thing is this bilirubin level is not the sole criteria which can determine recovery. Like in this patient, he had an improving INR, improving enzymes, improving creatinine and improving other parameters, but bilirubin was still rising. Despite that, we will consider this patient as improving. Bilirubin recovery in hepatitis A can take up to 6 to 12 weeks also. So after documenting improvement in blood parameter and documenting improvement in cerebral edema, we extubated the patient on day 10. And finally, we can say that as his INR has touched normal from 6.9 and he was out of cerebral edema, we have prevented and or avoided transplant. We were getting happy and planning to discharge the patient, but unfortunately 2 days after extubation, he had a fever spike. With fever spike, he had this surge response in form of tachycardia, tachypnea. There was increased work of breathing, for which he was started on high flow nasal cannula. This was his X-ray before extubation, and just 2 days after extubation, he developed new onset bilateral pulmonary infiltrates. So there was a possibility of ventilator-associated pneumonia, as patient was on ventilator for almost 10 days, or volume overload. He was having AKI, given lot of fluid. To discuss all this, I will like to invite my critical care colleague, Dr. Suma, to take the case further. Thank you.
Doctor, are you using Doctor, are you using transcranial Doppler RIMED in management, optimization, and monitoring of intracranial pressure? It will be much better than
True, sir.
and then your
Yes, sir. Sir, it is an important tool which can non-invasively help us to determine cerebral edema.
Yeah, we had done 2 workshops, and I think I had invited you to
Yes, sir.
come and visit one of them.
Yes, sir. Actually,
What's your view on that?
it is a useful. Yes, it is a simple modality which can be used from time to time monitoring. We can use it 3 or 4 times, even hourly basis. We can monitor. It can help us in dynamic monitoring of cerebral edema. Very useful, sir. In fact, we have placed a request for also. It is in the purchase department. Hopefully, we will acquire it soon,
because we are running high on the liver transplantation program.
Yes.
And we will be taking up more and more cases of acute liver failure for
I hope the request will pass on
Thank
immediately.
Good morning, everyone. So I'll be discussing about the post-reintubation course of events and the management in the ICU. So as already discussed, patient was reintubated post-extubation in view of increased work of breathing, and patient had developed fever spikes of 102 degree Fahrenheit, and on investigations it showed an increased WBC count and purulent secretions in the ET tube, along with new onset pulmonary infiltrates bilaterally on the chest X-ray, suggestive of ventilator-associated pneumonia. Along with that, patient had an overall positive fluid balance, along with compromised renal function and an impaired cardiac contractility, which was assessed with the bedside point of care ultrasound, suggestive of pulmonary edema. So at that point, we had 2 possible diagnoses with us. One is ventilator-associated pneumonia, and the other one being pulmonary edema. So in order to rule out the clinical dilemma, we have sent ET secretions for culture, HRCT thorax was done, and cardiac output monitor was applied in order to assess the hemodynamic status of the patient. And HRCT chest revealed ground glass haziness with patchy areas of consolidation and multinodular opacities in bilateral lung field, suggestive of infective etiology as well as pulmonary edema picture. So a small word about cardiac output monitoring device, FlowTrack. It is a minimally invasive advanced hemodynamic monitoring system which uses the arterial waveform analysis to assess the hemodynamic parameters. And hemodynamic parameters like stroke volume variation, systemic vascular resistance, and cardiac output, these were the variables which were measured continuously and updated every 20 seconds. And this cardiac output monitoring device helps in evaluating the hemodynamic status of the patients, and indices like stroke volume variation can be used to guide the fluids both intraoperatively and also in managing the patients in the ICU. And variables like cardiac output, systemic vascular resistance can be used to taper the inotrope and vasopressor support. And these were the patient's variables obtained from the cardiac output monitor with high cardiac output of 9.8 liter per minute and low systemic vascular resistance of 642 dynes per second per centimeter to the power 5, implying a vasodilatory or a vasoplegic state, which was usually seen in patients with acute liver failure and underlying decompensated chronic liver disease and in patients with severe sepsis. Patient also had a rise CVP readings, and the readings were like 12 millimeters of mercury, suggestive of fluid overload. So at this point, patient had a combined picture of ventilator-associated pneumonia and pulmonary edema.
What is the stroke volume? Stroke volume.
So amount of blood ejected by like for every beat, every heartbeat.
So what is the value of flow?
Sir, it's 75, normal value is 80 to 100.
What you have written?
So per beat, 100 per beat, every heart.
It is not per.
Yes. So on the arterial blood gas analysis, the PaO2 by FiO2 ratio was 97 with FiO2 of 70% oxygen, implying a severe ARDS picture, for which we have implemented the lung protective ventilation strategies as part of ARDS protocol, starting with low tidal volumes of 4 to 6 ml per kg idle body weight and high respiratory rate around 28 to 30 per minute in order to maintain the arterial carbon dioxide tension in between 35 to 45 millimeters of mercury, and PEEP has been titrated accordingly in order to maintain the saturation between 88 to 95%, and simultaneously targeting the plateau pressures less than 35 centimeters H2O in order to prevent the further ventilator-induced lung injury. Acinetobacter sensitive to minocycline was identified on the ETE culture, so the antibiotics were changed accordingly. And in view of persistent need for mechanical ventilatory support and for better tracheostomical toileting, tracheostomy was done on day 15. And conservative fluid management based on the dynamic flow track readings was given because of concomitant fluid overload picture and as well as part of ARDS protocol. So in spite of lung protective ventilation strategies, patients' oxygenation and ventilation parameters were not improving, and there was also an increased FiO2 requirement. So we have decided to proceed for prone ventilation. So prone ventilation was continued for like 12 to 16 hours per day, followed by supine positioning for the next 3 days. So there was actually an improvement in oxygenation and ventilation parameters, and the factors being multifactorial, like homogeneous distribution of compressional forces over the alveoli, which helps in improving the oxygenation and ventilation, and also it helps in correcting the ventilation perfusion mismatch, thereby correcting the hypoxemia, and also had an added advantage of a better drainage of secretions. And these are the ventilation and management strategies available for managing the patients with ARDS. We have already discussed about the low tidal volume ventilation, recruitment maneuvers, proning, and the last resort being ECMO. So we made sure that ECMO mission was kept on standby in the ICU. So as we can see on the arterial blood gas analysis, the PO2 by FiO2 ratio is actually improving. So it improved from 92.8 to around 317 and 315 after prone ventilation. And the patient was able to maintain the oxygenation parameters even in the supine position, and the radiological findings also gotten better in due course of time, and patient was improved clinically, started responding to antibiotics, and the WBC counts and procalcinotin levels were within the normal range. So we successfully weaned off the patient from the ventilator on day 21, and the tracheostomy tube was decannulated on day 23. Thank you, and I would like to call upon Dr. Hemanth.
Thank you, Dr. Suma. With almost 20 days in ICU care, patient has improved, his sensorium has improved, his infection has improved, his chest infection has improved. The plan was to shift to ward and start rehabilitation, but the patient has developed new onset shock in the terms of low new hypotension, hypovolemic shock, which also correlated with the biochemical parameters of low hemoglobin and increase in serum creatinine. And bedside ultrasound showing collapsible IVC with hemoglobin dropped from 8.4 to 6.7 grams per day. And subsequently, the patient has developed large volume melanic stool, suggestive of gastrointestinal bleed. So we did an urgent upper GI endoscopy to identify the onset bleeding site, but not able to identify the bleeding site. There is a esophagus and stomach were normal, and there is a gushing of blood coming from D4 to D3 of part of abdomen, part of duodenum into the D1 and D2 regions. So as we are not able to identify the bleeding site, we have taken interventional radiology reference for further management of the case. I would like to invite Dr. Neeshant.
Good morning, everyone. I am Dr. Neeshant, first year DM Interventional Radiology resident. So it was a case of acute hepatic liver failure, which is hepatic encephalopathy, which was managed successfully by the hepatology team. Then the patient developed ventilation-associated pneumonia, which was again managed by the critical care team. But then the patient had the hypotension with high volumic melanic stool. and the emergency urgent endoscopy was done. So after endoscopy, the patient underwent CT angiography, which was indicated for continued bleeding with unsuccessful endo. This is the CT angio axial image, which is showing a small branch of a gastroduodenal artery, which is seen to be extending into the second part of the duodenum, and the contrast blush can be very well appreciated over here. So the first image is the CT coronal image, and the second image is the CT sagittal image, which is showing contrast blush in the region of the second part of the duodenum. So after determining the site of the bleed, our main aim was to stop the bleed, right? So we took the patient to the cath lab and did DSA. The patient, for the embolization, we took the right femoral arterial line access, and using catheter guide wire combination, the celiac artery was hooked and the angio was taken. And then the super selective cannulation of the common hepatic artery was done, and which is into the gastroduodenal artery, using the micro catheter crossing across the celiac artery. Here we can see one of the branch of the gastroduodenal artery, which is showing frank contrast extravasation. So then the glue embolization was done using NBCA with lipidol, showing no any contrast extravasation at the site. The first image is before glue embolization, that is the frank contrast extravasation can be very well appreciated. Then the second image is after glue embolization, that is there is no any bleed, no contrast extravasation can be seen. So to conclude, the patient was referred to us from hepatology team for gastroduodenal artery bleeding, for which we did glue embolization, and then after successful embolization, the bleeding, we have achieved the hemostasis, and again the patient was referred to the hepatology team for further course of the treatment. Now I would like to call upon stage Dr. Saraswat sir for further to brief us about the further course of the treatment. Thank you.
Thank you, Dr. Neeshant. So, what we have then is a patient who has had multiple complications, and after about 32 odd days about 28, 29 days in the ICU, and after tackling these complications, we have finally come to a stage where he is stable. His hemoglobin had improved after this bleeding to about 87. The other parameters of renal function had normalized down to 0.8 creatinine. The bilirubin, however, had still been rising. It had actually, during the period when he was septic, had gone up to as much as 41 milligrams per deciliter, probably due to sepsis related to cholestasis, and this had started to gradually come down. Enzymes had normalized for quite a while now. Not normalized, they had dramatically come down to just about 2 to 2.5 times upper limit of normal from 300 times upper limit of normal. And the coagulation parameter, which Dr. Karan has been at pains to emphasize is our major guide to recovery of the liver, had been normalized now for quite some time. So with all these improvement in the kidney injury, improvement in liver function, so that we no longer had a need for liver transplant, and his infection, the ventilator-acquired pneumonia and fluid overload having improved and hemoglobin being stabilized, he was shifted out of the ICU and went to the ward, where we continued with his rehabilitation. So one patient who was perfectly healthy 5 days prior to coming to hospital had a very brief illness with fever and jaundice, went through 3 life-threatening complications. He could have lost his life to acute liver failure with cerebral edema, which often requires liver transplant. Next, after having come out of this on conservative management and ICU care, he had developed an infection, which again kept him 10 days in the hospital, required very stepped up ventilatory maneuvers to maintain oxygenation, and from which he also eventually, with a careful intensive care management, he came out, only to get a massive lower GI bleeding, possibly mycotic aneurysms or stress ulcers, which were eventually controlled with the help of our intervention radiology colleagues. And on day 28, 29, out of ICU to the ward, where he gradually recovered. As you can see, he was up and about, and finally we were able to send him home on day 33. So now, why exactly did we choose this case for presentation in this forum? The few points that I'd like to make from this case is, one is recognition, timely referral of a patient with acute liver failure. As We often see patients with jaundice, fever, and we have had the sad experience of many of them coming to us rather late where we couldn't really help them. The one test that must be done in a patient with jaundice and raised transaminases is to look for the INR, the prothrombin time. If that is prolonged, that immediately puts him into a very high priority category of acute liver failure. And as per standard global practice, such patients are best managed in a liver transplant center with aggressive management. We wait and expect and try for spontaneous recovery, but we have the backup of liver transplant which we prepare for in case spontaneous recovery doesn't happen. So this is not adequately realized and we are often getting late reference, so I thought we'd make this point. Again, I would like to emphasize the role of interdisciplinary management that we saw here. Our critical care colleagues, intervention radiology colleagues, nephrology colleagues who help us with managing the CRRT, HPV surgery team, I'll be talking about them later. All of them were involved at different stages, and this is one of the great things about our center, that we have this not just available but close coordination, person to person, one-to-one interactions, and these are very important in such sick patients to pull them out of these various complications. Finally, and most importantly, we took this up, I thought we must raise the awareness regarding the risk and the threats posed by hepatitis A virus. And the next few slides I'll try to tell you what exactly is the reason why we presented this. Why has hepatitis A become such a major problem now is because India is going through an epidemiologic transition where we are passing from a high risk, high infection area to an intermediate low prevalence areas in a rather patchy manner. The HIV paradox is that the higher the level of infection in the community, the lower is the health risk burden. Because when infection appears at a young age, immunity that is lifelong develops following a very trivial or a minor clinical illness, and the person is protected lifelong. However, as socioeconomic status and environmental conditions improve, you reach a stage where we have a large population of young people growing up who have never had childhood infection, they have not been vaccinated against HIV, and they get infected at an older age. At that older age, the severe response from the immune system you could see in this patient, 1% of people with acute hepatic failure in young adolescents and adults can actually develop acute liver failure, while up to 20% have a prolonged relapsing cholestatic course. Even autoimmune hepatitis can develop in these patients. So this is the experience we have had in the last 2 years at the Mahatma Gandhi Hospital. We have had 77 patients of acute liver failure who were admitted between June 22 and December 23, that is about a period of 18 months. And of these, 54 were due to hepatitis A acute liver failure, which is of the hyperacute variety. Jaundice encephalopathy interval is less than 7 days. And all these, as you can see, are young people in the prime of their life, 20 years, who come in with raised bilirubin, grossly deranged INR values, raised ammonia. 40% of them had acute kidney injury at presentation, and almost 41% of them met the severity criteria for requiring a liver transplant. With conservative management, including CRRT, 3/4 of these patients could be salvaged after prolonged ICU stay, and we could pull them back primarily because the livers were young, healthy, and they just needed time and support till the liver regeneration could kick in. However, the sad part of the story was that as many as 13, that is 26% of this very young cohort of people actually lost their life, some of them phoning within 24-36 hours of admission to hospital, just not giving us any time to pull them back. Only one of them eventually needed liver transplant, while 3/4 of them had spontaneous recovery, which is somewhat better than the global reported experience with HIV recovery and acute liver failure, which is around 50 to 60%, and close to what Manmohan told us is what happens after liver transplant. Here the patient's own liver gets back to normal. So many young people dying of a vaccine preventable disease is just not acceptable. And I would like to show you that this is not a unique problem only we are seeing in Rajasthan. If you look what is happening in our country, every year for the last, there are 23 states in our country where we are developing outbreaks and episodes of severe acute liver failure. Recently, last year we had been to Ghanta, and around that time there was an outbreak of HIV with deaths that was going on and was highlighted in the local press. Just 2 days ago, we had this report from Bengaluru, which is reporting a high incidence of acute liver failure. The state in India which has the best documented health care and attention given to to acute HIV is Kerala, where for the last 20 years there have been as many, last 11 years there have been as many as 20 outbreaks of HIV that have been well documented and worked up, and the latest one in 2024, almost 2,000 people have been infected with the loss of lives, and this is the report of this ongoing epidemic. In fact, the government of Kerala has passed orders and has GOs about the management of acute liver failure and prevention of hepatitis A, including vaccination of young adults as well as food handlers. Now, as I said, there has been a change in epidemiology. India, this is a graphic from 2012, until the turn of the century, India was a hyperendemic area where 90% of the population was HIV positive by the age of 10 years, thus not really at risk of severe clinical liver disease as we are seeing. But this changing epidemiology shows us that now this number has come down to about 50-60%, and well worked up series from NIV Pune and elsewhere show that the age at which infection HIV is being acquired is transmitting to adolescents and young adults and who have low immunity, and particularly in the higher socioeconomic class. So what should we do about it? Well, vaccines have been available for almost 40 years for hepatitis A, including inactivated vaccine like Havrix and vaccine, and live attenuated vaccines which are available readily in India. They are highly effective vaccines which give you protective levels of immunity after one injection for the bioattenuate for the live attenuated vaccine, and 2 injections are recommended. The vaccine costs 1,500 to 2,000 rupees. Unfortunately, the vaccine strategy for India has not been well established. While Indian Academy of Pediatrics has recommended that above the age of 1 year, every child should be inoculated for hepatitis A, in practice this is not happening. And amongst adults, with this in the last 20-25 years, a large proportion, 12 to 40-year-olds in our country, about 50% of our population have grown up without exposure to HIV and are now vulnerable to this severe illness, which is borne out by the repeated episodes of and reports of HIV outbreaks and epidemics from different parts of our country. So what can we do? What problems should we take? At least we thought that we should sensitize the audience here. All of those who have not taken HIV vaccine, where and how you will get it, because this is foodborne, and street food eating and other habits make you vulnerable to this. People are not very keen to change their lifestyle, but they can certainly protect themselves. And with the Emeritus Chairman Sir being here, we thought we would put up, our department has long been thinking about this, that we can actually work to make charity begins at home. We should start with ourselves and try and make our campus a hepatitis-free zone by all these tests and vaccines are readily available. We are doing the IgG anti-HIV screening. People who are negative for this should get vaccination. So this is something that we would look forward to. And with this, I think we'd like to introduce you to this.
Last year I was diagnosed with acute liver failure. Through my test I got to know that my SGOT were around 14,000. So I was admitted in Gandhi Hospital, Jaipur on 26th of July 2023. I was there around for 1 month, in which 20 days were ICU and 10 days were ward. And throughout my journey, Dr. Karan and Dr. Anand's team were very cooperative, and through their tireless effort, I was able to recover from that deadly stage. And today, 1 year after that, I'm doing my stuff, enjoying my life, and my family is also very grateful for the effort that they have done for me and them. So really want to thank Mahatma Gandhi Hospital for that. Thank you.
This young man is now doing his BTech in engineering in Manipal. He's perfectly okay and he's in regular touch with us. This is one of the most gratifying experiences we can have in salvaging a life. Finally, it remains to me to thank and acknowledge the contribution of the management of MGUMST and all our colleagues in different departments who have helped in taking care of this very sick young man with acute severe illness, from which we could, fortunately, with the grace of God and the cooperation of the critical care medicine, our surgical liver transplant team, Department of Radiodiagnosis and Interventional Radiology, blood transfusion support from IHBT, and of course the great amount of effort that our CCR review committee puts in to improve the quality of our presentations. Thank you very much.